Yes, I started out as a general surgeon. I was a resident in Buffalo from 1973 to 1978. And during that time, John Border became my mentor. And John was a trauma surgeon who got hooked up with Professor Allgauer in the early 70s and learned about AO. And he wanted to teach some of us that. So he sent me over to Davos, which was in the mid 70s, the only real place that they had courses. So I took the basic course in Davos in the old Forcings Institute in the basement with bones that weren't human, but they were real. I think they were pigs or sheep or something. That was 1975. And when I was there, he talked to Martin about sending me over for a mini fellowship, those 3-month fellowships that they had. And so I spent the winter of 77 with Peter Mater in Davos. I finished my residency and went back to Davos for the winter of 79, mainly because I wanted to ski. But when I finished and started my general surgical practice in a small town in upstate New York, I felt I was a fully trained fracture surgeon. I had not only been to Davos twice, and I'd taken the courses, but when I was a general surgical resident, we used to alternate fracture call with the orthopedic department, so that when I was on trauma service, every other night I was doing fracture work. So I felt very comfortable doing all fractures in this small hospital in Warsaw, New York. But what I realized was that I was vulnerable to lawsuits. I was not an orthopedic surgeon. I was a general surgeon who happened to be very well trained in fractures. Bernd Cloudy was in Davos when I was there in 77. He was doing his PD at the Institute, and we became acquainted, and then I used to do some AO teaching with him after I got into practice in general surgery. He went to Dallas, I think about 1979, 1980, to help train the orthopedic surgeons in Dallas the AO method, but he couldn't stay. And I picked up the phone in May of 1982 to say goodbye to him. And he said, "Larry, you ought to come down to Dallas and continue what I'm doing here. Why don't you do an orthopedic residency?" The next day, Vert Mooney, the chairman, called me up and invited me to come down and interview. I left a note on my dad's desk that said, "I'm going to Dallas to look at an orthopedic residency. Will you round on my patients?" And I got the position and started the following year in July of '83. That's how I became an orthopedic surgeon, totally because of John Border putting me in Davos, and I got to meet some people who made this whole thing happen. When I was in Buffalo as a general surgical resident with Dr. Border, with John, we were alternating fracture call, as I said, but it gave John the opportunity to see the difference between ICU patients who were treated with early fixation, which we did. We generally plated the femur in those days because we were AO taught. And the orthopedic department was still treating femur fractures and traction. And John told me, as he studied the ICU patients, that he would see notes in the chart: patient doing well, patient found dead in bed on the traction patients. And he knew why they were dying. And he knew that early fixation made a difference. It saved lives. So when I went to Dallas, I'm totally convinced early fixation makes a difference. I guess I was there like 3 months, and Ken Johnson says, Larry, would you go to this symposium on fat emboli? That. Have you seen fat emboli recently? I haven't seen it in the, since that time. But that's what ARDS and pulmonary failure, it was fat embolization. And it was a general surgical symposium. And Ken asked me to sit in for him to talk about fat embolization and fracture fixation and its consequences. The general surgical department in Dallas didn't believe me. They absolutely refused to believe that the fracture has anything to do with fat emboli. And I wanted to say, where do you think you got the fat from? So I went to Ken and said, we got to do something. And we sat down and put together a prospective randomized study of early fixation of the femur fractures, and had John Weigel, the young general surgical trauma surgeon who didn't believe us, to be part of the study. So we had to have somebody offset our bias. We did the study for 2 years, and the results. Ken was as you know, did his fellowship in Seattle and knew early fixation from his time there, and that it made a difference. So we were on the same page. We just had to convince the general surgeons, and then ultimately we convinced the world. John was a character for sure. He was very smart. He had several degrees and was anyway, he was about a decade ahead of his time. Stuff that he was writing in the 70s that people didn't believe turned out to be correct in the he had a terrific brain, and he read everything and remembered it. He knew everybody. He was well respected. He was more respected outside of Buffalo than he was inside of Buffalo, which is not uncommon. And I don't really know when he and Professor Allgauer got together, but it was the early 70s, and he, knowing what he knew and having his little mini lab in our small ICU in the hospital in those days, he and Martin really hit it off. Ted Hansen once told me that, of course, Ted was doing early fixation in the early 70s too, because he knew it worked. But he said, I didn't know why it worked until I met John Border. And then not only did I know it worked, but now I know why. That's the kind of brain John had. He was well above his time. It was a great time to be with him, because he was digesting all this new information, and we were pretty primitive in the early 70s. I mean, volume cycle ventilators just came out. Management and the resuscitation and the management of the trauma patient was primitive. My first paper was in open fractures that I wrote for my for the graduation in 78. It was published in Journal of Trauma. And when we were doing early washouts and fixation of all open fractures. We used to plate them in those days, and people said, "Oh, you plated an open tibia? It had to get infected." We had 50 cases of all kinds, and the only one that got infected was a psychotic patient who jumped and had an open calcaneal fracture. We fixed it, and she jumped again and split it apart, and she got infected. But we had essentially no infections in our open fractures that I reviewed. And when I was looking at the literature at that time, writing the paper in '77. People didn't know what to do with open fractures. They put them in, they wouldn't wash them out properly. They'd put them in casts, and then they'd pus out and they'd say, oh, you can't do anything for this. That's how primitive we were. So we've come a long way. The early AO, as you know, in the 60s, you couldn't get the trays, the instrumentation and implants until you took the course. And the only place to take the course was in Davos. There was a course in Columbus, Ohio, which was really a vet course in the 70s, but otherwise you had to go to Davos. And when I was thinking about talking to you about this, think of the hundreds of courses that go on every year. And they started out in Davos as the single course that you had to take in order to use the instrumentation. Other thing that I've said before is that it was a good thing that the Swiss were the inventors of the philosophy and the instrumentation and implants, because they could take those royalties and put them back into research and education and all the money that they've spent that brought the world up to their standards. If a US group of surgeons invented that, developed it, where do you think those royalties would have gone? Yep. Yeah, and it would never have gotten out. It would have never gotten out. But the Swiss, the professors in Switzerland made enough money without having to take royalties, and we're very lucky that the Swiss were the way they were. The decision was because of my son. My son Christian enlisted in the Army not too long after 9/11. He went in May of '03, went through basic, then joined the 101st Airborne, deployed to Iraq twice, and his second deployment, he was driving a Humvee, and an IED, a roadside bomb, blew up the Humvee. Fortunately, it was a reinforced Humvee. The engine was totally gone. There was a 10-foot crater, but he was injured, but he's okay. I, at that time, had no idea that I could get into the military, had no thought about going into the military, but I was a natural. I was a general surgical trauma surgeon. I was an orthopedic trauma surgeon. I would be great at helping those kids that got themselves blown up. And I was at a military reception after the OTA, because I had been in Landstuhl as a Landstuhl scholar, and they were looking for orthopedic surgeons because the war had gone on so long. They had a critical shortage. And I said to one of them, I said, oh, I would enlist if I wasn't so old. And they said, oh, but you're not so old. I said, really? Yeah, they said there was an age waiver because of the critical shortage. So I put my foot in my mouth and went back to Buffalo, went to the recruiter. And it took me almost 2 years to get in because of all the age requirements, and I was commissioned as a lieutenant colonel. It's not something I would have done if Christian hadn't enlisted, hadn't been injured, and it put me in a position of wanting to help out and give back to the military for what they did for him. The deployments were interesting because as a reserve physician in the Army Reserve Medical Corps, by regulation they can't deploy us for more than 90 days. That's boots on ground. That's in country. I did a 90-day deployment in 2012. It wasn't too bad. We weren't that busy. It, we saw some stuff, but it wasn't too bad. When I got back, my commanding officer asked me to command a forward surgical team out of New York City, and they were deploying 6 months later. If I command the unit, I have to go for the duration, and that was 9 months. That deployment was busy. We saw, as they say, a lot of shit. Interesting. You don't know what you're. I had seen it. I'd read the books. I tried to get myself as prepared for it as possible, and you can't. You know, these young kids come in with their legs blown off. It's just something you never see in a civilian practice. But you, like any trauma patient, you just deal with it. It's the aftermath that gets to you. And I came back and I said, I'm not going back there again. I'd had it. I'd seen enough. I'd done enough. A year later, I would have gone back. But when I turned 68, they said that's the age that you have to retire. So I didn't extend, as they say. It is a funny world because you're there with a small group of medics, nurses, other docs, that all you're doing is waiting for the next medevac helicopter to come in. You have no other responsibility. Your adrenaline is running all the time, and you're alert all the time, because we were in a forward operating base that was mortared almost every day. And so not only were we worried about the next casualties, but we were worried about ourselves. Your brain gets fried after 9 months of that. You really are beat up. But I wouldn't have gone back when I came out, but a year later I would have, and I wouldn't change it. I'm not the same. I have some PTSD. But it was the most rewarding thing I could have ever done. And I've done a lot of rewarding things, but taking care of young soldiers, I went in with the mindset which was the wrong mindset, that I don't want to lose a single patient. If they get to us alive, we're going to keep them alive. And we had some very dead young people that no blood pressure, no pulse, and within 15 minutes you can resuscitate these kids with the way we're set up, and the walking blood bank that we had. We pounded fresh blood into them, and we could save them, and we did. But that was a silly thing for me to want to emphasize, because that if I hadn't achieved that, it would have been difficult for me to deal with. Part of my problem was my son, who had been injured and was in a similar situation a few years before that. So every casualty that came in, I not only thought about the casualty, but I thought about their folks back home, because I was one of those folks at one time. And that got to me. And about 6 months into it, I said, you got to stop this. You got to become much more objective. You can't be living the lives of all these kids that are coming in. But and I did. I figured it out. But it was a hard thing. It was a very hard thing. Oh man. the most important thing that you can do is listen to your patients. Um, we don't, over the years, we always get too busy and we don't spend the time to listen to what their problem is, to then educate them on what their problem is. I know that's hard because it takes time, and time is money. But if you do that, and then you have an educated patient who will help themselves, help you make them better. It makes all the difference in the world. I was very lucky that I didn't have to have a large elective practice. I was really a trauma surgeon. I morphed into some total joints because of the county hospital I was in, but I didn't have to do a large private practice to make my money. So the patients I had the luxury of spending time with them and getting to know them, and then listening to them, and then examining them. Put your hands on them. Find out what's wrong. Don't look at the X-ray and the MRI and the CT scan, and look at your computer, tell them, oh, you need this, and walk out of the room. And they go, what'd he say? What'd he say? They had all these questions for you. So listen. Yeah, there's a lot of that. And besides the military aspect of what I did, because that was rewarding in many ways, but educating young surgeons. I was program director for a number of years, and then chairman for 12 in Buffalo, and teaching residents to be good surgeons and good doctors is extremely rewarding. And you know that because you're in the same position I used to be in, and you're one of the people that I taught, so that we're here talking together. But when you have that opportunity, you realize that your knowledge and your experience, and hopefully your wisdom, is exponential. Every trauma patient that you've seen in your life, I've had an effect on, because I affected you in how you managed that patient. And then you multiply that by all the residents that I trained, and all the patients that they've seen. But what could be more rewarding than to pass on your knowledge, wisdom, and skill? And that goes to all those other patients as the residents go out and treat them. I've got a few. I will. The most memorable one, maybe because it was the most scary, was when I was a general surgical resident. And I know we're talking orthopedics, but I got to tell you this story because it's a retarded young boy, about 16, 18, and he's got an upper GI bleed. And I'm a third-year resident, but I happened to be a chief resident at that time because of the way things worked out. So he's my patient. I'm going to do surgery on him, and the attending is obviously going to help me, and I've got a junior resident with me. So we go to surgery to basically do a hemigastrectomy on him. And the attending says, go ahead and get started. And he never shows up. And when I open the kid up, he's got situs inversus. His liver is where his spleen should be, and his spleen is where his liver should be. And the anatomy is all screwed up. And so I'm doing a gastrectomy as a third-year resident on a situs inversus kid that's bleeding out. That's scary. That is really scary. You gotta do it all backwards, and you gotta hope that you don't cut something that kills them. that was the worst case I was ever involved in. But orthopedically, I had a young lady with about 7 months pregnant with a both column acetabular fracture and protrusio. That putting her to sleep and operating on, 2 inches away from an infant's head and worrying about whether that infant was going to stop breathing or the heart rate go down. That was the worst. We did okay. The baby did okay. She did okay. We couldn't make it anatomic without really getting the fetus screwed up. She ended up with a total hip, but did fine, and the baby did fine. But that was not a fun case.